Okie doke. We're good to start? Great. Good afternoon, folks. Happy to have you join us this afternoon for our breakout session titled An Overview of CMS-Developed Indices Measuring Health and Healthcare Equity / Disparity Performance. As background regarding healthcare, quality spans 6 broad domains. Quality care is care that is safe, effective, patient-centered, timely, efficient, and importantly, equitable. That is ensuring that the provision of care does not vary in quality based on patient characteristics such as race, ethnicity, gender, identity, sex, sexual orientation, disability status, preferred language, or other factors. To ensure equity in care quality, we need valid tools that directly measure healthcare inequities and trends in healthcare inequities that enable healthcare organizations to both understand and track their performance at delivering both high and equitable quality care. And to that end, this afternoon, we'll spend time discussing, comparing, and contrasting some of the work that's currently underway, happening at some of the centers and offices at the Centers for Medicare and Medicaid Services, to develop various health equity and/or health disparities index or composite measures that describe various entities' performance at delivering equitable quality care. We have with us speakers who are conducting incredibly important work in this space, representing the Center for Medicare, the Center for Clinical Standards and Quality, and the Office of Minority Health at CMS. Our first panelist is Dr. Sarah Gayo. Dr. Gayo is an experienced leader, program manager, and social scientist at CMS. Her division in the Center for Medicare oversees the Medicare Part C star ratings, as well as implementation, analysis, and reporting of numerous patient surveys. Dr. Gayo's previous work includes an assistant policy analyst role at the RAND Corporation, supporting the Institute of Medicine's board on the health of select populations, and also served as a Fulbright scholar in South Korea. She has co-authored dozens of peer-reviewed research articles and reports about healthcare quality and equity, and holds a PhD in policy analysis from the Pardee Rand Graduate School. Our second panelist is Dr. Vinitha Meyer, who is a healthcare researcher with more than 20 years of experience and is currently serving as the Deputy Division Director for the Division of Quality Measurement in the Center for Clinical Standards and Quality, or CCSQ, at CMS. She leads a team of public health professionals in the development, maintenance, and implementation of clinical quality measures for numerous CMS quality reporting and payment programs, including for dialysis facilities. Dr. Meyer executes tasks in collaboration with CMS leadership to address the national quality strategies and agency priorities, including health equity, maternal health, and patient safety across various hospital settings, by driving quality improvement, prioritizing outcomes, and making information more broadly available to enrollees. Finally, I will be serving as the third panelist. My name is Jess Maxit. I am a social and behavioral health scientist with a PhD in human development from the University of Connecticut and postdoctoral training in epidemiology from the Johns Hopkins Bloomberg School of Public Health. My work centers health equity and healthcare quality equity across CMS's programs with attention to CMS OMH's key populations, including those who are racial or ethnic minorities, sexual or gender minorities, persons with disabilities, individuals with limited English proficiency, and those who reside in rural, tribal, or geographically isolated areas. I joined CMS's Office of Minority Health in March 2020 as a public health advisor, and now work as a technical director focused on research and data analysis in OMH's Data Analytics and Research Group. To begin, I'll say a bit about indices and composites in general. We'll then move into talking about some of OMH's work in this space to talk about the Health Equity Summary Score. Vanitha will speak next about the work that CCSQ has been doing. And finally, Sarah will speak about the work that the Center for Medicare, or CM, has been doing in this area. We know that upstream drivers of health, including social, economic, and environmental factors, affect a multitude of health processes as well as health outcomes. We also know that these factors drive patterns of health inequities, including inequities in things like exposure to disease, underlying health conditions, and health comorbidities, as well as access to and engagement in high-quality healthcare. We know as well that these disparities exist across sociodemographic strata, including across race and ethnicity groups, across disability status groups, and across income level groups as some examples. We also know that measuring and reporting health equity and/or health disparities performance may assist organizations in improving the care that they deliver, particularly for underserved enrollees, and ensure that the quality of care that they deliver is equitable for all enrollees that they serve. Indices or composites can provide summative snapshots that are succinct and usually pretty easy to understand as a basis for promoting high and equitable quality healthcare, particularly to underserved enrollees. And again, there are several centers and offices across CMS that have been developing and are continuing to develop these health equity and health disparities indices and composites for various uses and applied across different settings. I'll just sort of put a plug that I think one of the interesting things about this panel today is you'll get a chance to hear about some examples of those indices and panels as a way to sort of compare and contrast the different applications of this work and how these different methodologies look. I'll start today by talking about some of the work the Office of Minority Health has been doing. We call our composite measure the Health Equity Summary Score, or HESS for short. We've been working on this for quite some time, and I will be talking specifically today about the application of the HESS methodology to Medicare Advantage, although we have explored and are continuing to explore opportunities to apply this methodology to other data and other settings. I'd like to acknowledge that although I am presenting this work today, there are a lot of people on the HESS team who have contributed to not just these slides, but this work over the last several years. I want to spend a moment sharing with you this flow chart, which I think describes at a high level the kinds of things that HESS provides, that HESS calculates, that, for example, a Medicare Advantage plan would see in us sharing back their HESS information with them. So this flow chart has a number of steps. You can see from the left, which are the sort of most granular scores that are some of the most granular scores that are calculated, all the way through to the most summative score, all the way on the right in gold, which is called the overall summary score. Some of the things that I want to highlight that are important to know about what HESS does and the kind of information that HESS provides. HESS, and we'll go more into detail on this on the next slide, HESS takes a number of both HEDIS measures that capture clinical care quality and CAHPS measures, which capture patient experience, and look at a Medicare Advantage contract's performance across both race and ethnicity groups and across those who are and are not dually eligible or eligible for low-income subsidy. Scores are calculated, as you can see, from both the top and the bottom of the screen for each of those groups. A plan gets an overall summary score that is a combination of all of the different kinds of scores, as well as their performance across race and ethnicity and dual eligibility and low income subsidy status, all into one overall score that again provides them a summative snapshot of how they're doing. But we also provide them more granular information on how they're doing for race and ethnicity, specifically for how they're doing for dual and LIS enrollees specifically as well. Another thing to point out is that the HES provides a point-in-time assessment, so we're giving folks a cross-sectional score of how they're doing based on their most recent data available. We've also heard that there's interest in understanding how plans do over time. And so there are two kinds of improvement scores that are calculated via HES. The first one is looking at how a contract is doing against itself over time. So in baseline data, calculating how it's doing across, say, for example, race and ethnicity groups, and then in the more recent data available, how is it doing against how it did a couple of years ago? Is it getting better or gaps narrowing? Another kind of improvement score is looking at how each group is doing against the national average for that group and looking to see if gaps are closing there as well. So built into HES and into the two improvement scores are sort of attention to a within entity disparity assessment as well as between entity disparity assessments. There are different kinds of benchmarks that are used as well. So the last thing I'll say about this before moving to the next slide is that we, depending on the kind of score that is calculated, HES thinks about the national average for the same group and can provide that as a benchmark for a score. It's also providing benchmarks for the leading group for a given measure. So for example, the Asian and Pacific Islander group may be the highest performing group for a given measure, and we'll compare all groups against that particular group's performance for a given measure, for example. There are currently 14 different CAPS and HEDIS measures that are used in HES, 7 of each. You can see that we've considered sort of covering a combination of different measures for HEDIS. There are a number of diabetes-related measures. There's one high blood pressure, controlling high blood pressure measure. There are a few cancer screening measures. Under MA and PDP CAPS, which represents patient experience, we have a number of measures as well, spanning customer service, patient-provider communication, getting needed prescription drugs, and others. And as I alluded to on the earlier slide, currently the MA HES has 2 grouping factors. So we're, race and ethnicity is the first grouping factor, where we're comparing across Asian American, Native Hawaiian, and Pacific Islander, Black, Hispanic, and white groups. And then our second grouping factor, where we're stratifying these measures across, is dual eligibility or eligibility for low income subsidy status. It's a 2-level category, either yes or no. There's a lot on this slide, but I think it's important to highlight a couple of things. We've gotten questions about whether HES is fair. And so there are sort of 2 ways that we've approached this really broad but important question. The first one is whether our fairness safeguards that we have in place, our expectations for data quality, in some way bias against plans or contracts that we would ideally like to have a HES, right, as a quality improvement tool. And the second one is, among those plans that do get a HES, what does the distribution look like among high, medium, and low performing plans against how they look demographically, right? So one of the things that we found when we looked at this was that plans that were omitted from receiving either a CAPS or a HEDIS HES tended to have lower percentages of individuals that were dual or LIS eligible, tended to be lower percentages of individuals who are Black or African American, and for CAPS tended to be have fewer racial and ethnic minorities overall. To us, this was promising and what we sort of hoped to see. With regard to scoring distribution for HEDIS, we saw that the highest performing plans had higher percentages of Black, Hispanic, and dual enrollees, which we were also pleased to see. If the opposite were true, the lowest performing plans had the largest shares of those groups. I think it would be important for us to perhaps sort of reconsider our methodology. The one area that we're sort of thinking about a little more is with regard to patient experience CAPS, specifically for duals. You'll see that the largest share of duals, 61.4%, are in the lowest performing plans. The next couple of slides are going to talk about a pilot test that we did at the end of the year. So while we are continuing to iterate on the methodology itself, making improvements all the time, we're also thinking about what are the best ways for us to actually share this information that we're calculating with contracts. That's ultimately the goal, right? For us not to keep it, but to share it with them. Some of what we did in the middle of last year was actually build a dashboard, and we worked with the Center for Medicare to do this. We are piloting a dashboard where we're actually sharing this information through the Health Plan Management System website, or HPMS. This is a website that plans are already deeply engaged in for various reasons. We felt that this was a great space to put HES to hopefully facilitate engagement in it. This was an opportunity for Medicare Advantage organizations to see their pilot data and provide us with feedback. Provide us with feedback on how interpretable the information was, how the information looked in the dashboard, the number of resources that we provided, the quality of resources that we provided, and currently, post-pilot, we are actively engaged, our entire HES team, in finding ways to streamline the dashboard itself to be responsive to the feedback that we got from plans. We recently conducted listening sessions with plans to learn more about some of the things that they're hoping to see improved upon in the pilot. The next couple of slides I'll go through fairly quickly, show you obviously, this is just an example, de-identified, but this is something a plan might see in their dashboard. The next couple of slides are not exhaustive. This is not everything you see in a dashboard, but just to show you a couple of the features and sort of the way in which we're presenting the information. So this first slide is showing a plan, their overall summary score, which again is that very high level summative snapshot of how they're doing, collapsed across all the different kinds of scores that they receive. So how they're doing cross-sectionally, how they're doing over time, how they're doing with regard to race and ethnicity, how they're doing with regard to duals. They also receive an overall summary score, which is again a collapsing of how they're doing cross-sectionally and over time. Similar thing for the dual and LIS score. Another thing we provide them with is what their contract demographics look like against what the national average across all plans that received an MA HES look like, just so they kind of get a sense of where and how their served population might look different than the average. One of the things that we heard from contracts was that they wanted to know not just how they were doing against everyone, but how they were doing against other plans that looked similar to them in some sort of meaningful way. So you'll see that we're showing them here on the left side how they're doing overall against everyone. But then there are other comparisons that we make, like plans that are a similar age. So if you're a younger plan, you might be interested in how you're doing against other younger plans. If you're a small plan, you might be interested in how you're doing against other small plans. You might be interested in how you're doing against plans in your region or plans who have a similar percentage of duals. So these are different kinds of comparisons that help plans contextualize their performance in different ways. Another quick snapshot, I think the last one, this is just an example of what the resources look like. So these are just some, certainly not all, but we tried to provide a number of different resources that are specific to some of the kinds of measures. For example, we have a couple of diabetes-specific resources, one annual flu vaccine resource, but then some broader resources around data strategy, our data collection. And then in closing, I want to share a little bit about the feedback that we received from plans about this dashboard. Overall, we heard that it did add value and that it helped plans think about ways that they might consider health equity improvements. They did see, however, opportunities for us to refine the dashboard. In particular, we heard that the way that we present the cross-sectional score was a little confusing. And so we've, again, had some listening sessions, tested a couple of different ways that we can present that information. We've also heard that there might be some opportunities for us to add additional documentation above what we currently provide, including an annotated user guide that helps people understand every feature of the dashboard, how to use it, how to interpret it. And then finally, these are just some of the things that we're thinking of doing right now or are actively already doing with regard to the dashboard. We are, again, having conducted listening sessions. We're making updates to documentation, making sure things are as easy to navigate as possible. We're working on supplemental materials, including potentially developing a national level HEST report that provides information on how plans overall, on average, are doing. This is something that we heard from plans that may be too new to receive a HEST, but are interested, again, just to have some kind of a benchmark to understand performance for each of these grouping variables. And then finally, we're thinking through opportunities to offer additional training and technical assistance. So we have a health equity TA mailbox, but we're thinking about ways to make communication clear that we have that as an avenue for plans to access as interested. And I will close there and hand off to Vinitha, but this is my contact information for any questions we might not get to later.
Thank you, Jess. Good afternoon. I'm Vinita Mayor. I'm going to present another health equity index. As Jess mentioned, we have a couple of indices that CMS has been working on from different components. And so to switch gears a little bit from the MA plan, I'm going to talk about the hospital programs. And so the health equity index that I'm going to focus on is for the hospital acute care setting. And so up front, I just wanted to let you know this is a work in progress. It's a concept that we are trying to kind of get more feedback on and, and work towards developing one that is more comprehensive. So this is an initial step in trying to come up with a health equity index. So there were three objectives that we were trying to look at when we started to develop this index. The first one was to actually construct a single equity score, which summarizes multiple measures and the social and demographic factors. I'm sorry, have I not moved the slide? Okay, there we go. The second objective was to actually summarize the results of the CMS disparity methods across a range of measures and socio-demographic factors to provide more accessible information about the differences and disparities across hospitals. So some of you may be familiar with the CMS disparity methods. We do have on the hospital side what we call the within disparity methods and the across disparity methods, and that's available for anyone's additional information on the CMS website. So we are trying to use those disparity methods and build that into the health equity index that we are trying to develop. So that was kind of like the second objective. The third one was to develop a single score that provides more information that's more easily understood across various hospital settings and the beneficiaries as well. So as I mentioned earlier, the two methods that we were focusing on is the within hospital disparity method. This method focuses on the differences in the quality of care between patients with and without a SDF within an individual facility. So this is just a hospital. What this basically means is, will patients with an SDF at this facility have worse health outcomes than patients without that particular SDF at the same facility? So that's like the within hospital disparity method. The across method is comparing performance across facilities by calculating a facility's outcome rate separately for patients with an SDF. So it's the same SDF, but comparing hospital A with hospital B. And so how does hospital A perform for their patients with an SDF compared to how facility B performs for the patients with the same SDF? So this is kind of like the basis of the methods that was used in constructing the HEI. So What we did next was we kind of took a few of the measures, basically about 13 of these measures. There's like 11 readmission measures and then 2 mortality measures as like a first step to construct the HEI. And we used 2 SDF. One is the dual eligibility status, the second being the ADI. And so as you see on the slide, we tried to kind of get a tally of the hospitals that have both. And so if you look at the first column and the second column, you see the number of hospitals that actually report and we have data on. But then the third column is like when you look at both of those, of course, it drops down. And so you see we don't have that many hospitals that can actually meet all of the criteria for both of those. Moving on, so how we constructed the index was we used a single methodology approach, which is if assign each patient a single any social demographic factor. So it's 1 if dual eligible or ADI ranking of greater than 85, and 0 if otherwise. And recalculated all the within and across scores for every single measure using this single risk factor. And so applying the following calculations, we constructed an individual score for across hospital equity and a single score for within hospital equity, each containing 13 measures that you saw on the previous slide. So combining the within and across scores from the HEI kind of looks like this, where you have the within disparities, and then you have the across disparities, and then you have the data, the scores for each of those 13, and then you pool them into one overall HEI. And so what we have on the final slide here is an index. So this has basically been standardized. So there's a lot of calculations that went into each of these measures, and each of these measures by themselves are calculated using a different regression methodology. So each of these 13 have their own score, and then you pull them up to get this overall score, which has been standardized, so it's kind of easier to summarize and understand. And so the scoring basically goes from a negative to a positive, and then so you can see the standard deviations, and the mean being a minus 0.05. And so higher is better, meaning more equitable, implies a ceiling effect, and this is just reporting hospitals only on this slide. So the overall index is basically, we try to kind of put this in context to the hospital star ratings. This is just an initial look to see how this would, we have not used any other variables as of now, because we're kind of still exploring this concept. And so the higher quality hospitals have a higher equity. So that's kind of the very first step that we have kind of made an assessment with this score. So that's basically a description of the HEI. So we're ready to take questions when we're done with the full panel. Thank you.
Right, thanks, Vanita. The final index that we are covering today is the Medicare Part C and D Health Equity Index, also known as HEI. My name is Sarah Gallo. I'm from the Division of Consumer Assessment and Plan Performance, and I wanted to acknowledge my team at the Center for Medicare who also helped develop this index as well as develop this presentation. So before I describe our HEI, I wanted to give some background on the Part C and D star ratings for those who might not be familiar. This program measures quality and performance for Medicare Advantage, or MA, and prescription drug plans, or PDPs. The star ratings are publicly reported on Medicare Plan Finder, and they're used for quality improvement, marketing and enrollment, and there's also incentive payments tied to the star ratings for Medicare Advantage plans. We developed the HEI reward to reward MA and PDP contracts Thanks. For excellent performance, we wanted to reward them for their excellent performance for enrollees with certain social risk factors, or SRFs in this presentation. And I also wanted to note that in this presentation, I'm using the terms contracts and plans interchangeably. So the HEI summarizes plan performance for enrollees with social risk factors of receipt of low-income subsidy, dual eligibility, and disability status across existing star ratings measures into a single score, and it uses data from the 2 most recent measurement years. The score that a contract receives on the HEI is then translated into a reward that is added to their overall and summary star ratings if they qualify. The HEI was proposed and finalized in regulation in April of this year, and it will be implemented beginning with the 2027 star ratings. So initially it will cover the 2024 and 2025 measurement years. And just to note, the 2027 star ratings will be released in October of 2026, and they're for Medicare beneficiaries to choose their plans for 2027. When we developed the index, we carefully considered its structure to ensure that we had the right incentives. We considered sample size limitations because we wanted to avoid rewarding large contracts over small contracts. We considered the proportion of a contract's enrollees with social risk factors to avoid rewarding contracts that serve very few enrollees with social risk factors. And we determined a minimum score on the index to receive an HEI reward, since we wanted to only reward those contracts with high relative performance for their enrollees with social risk factors. Additionally, we wanted the index to be easy to understand. We wanted to minimize the number of years of data needed to calculate the index, because if too many years of data are needed, the newer contracts would have to wait longer to be measured using the HEI. It'd be more difficult for us to introduce measures to the HEI and account for substantive measure updates in the measures included. And using 2 years of data also allowed us to more reliably measure small contracts by combining the data across the years. Finally, we wanted the index to be flexible to ensure that we could update the measures included and potentially add social risk factors over time. We wanted to promote contracts improvement and performance for enrollees with social risk factors, and we wanted to minimize sensitivity to measurement error in the index. So to avoid rewarding contracts that serve very few enrollees with social risk factors, we established a tiered threshold for the minimum proportion of enrollees with that low income subsidy, dual eligibility, and with disabilities. In the first tier, we have contracts that have at least the contract level enrollment median of those with social risk factors, and these contracts are then eligible for the full HEI reward. In the second tier, we have contracts with at least half of the contract level median up to the contract level median of those with social risk factors, and those contracts then are eligible for half of the HEI reward. To calculate the HEI score, we look at the distribution of performance among enrollees with LAS, DE, and disability combined into one group on each of the qualifying star ratings measures in the index, and we divide their performance into thirds. Contracts are scored on each measure in the index based on which third of the distribution their performance is in, with the top third of contracts receiving 1 point, the middle third receiving no points, and the bottom third of contracts receive -1 point for each of the measures. We repeat this analysis for each measure in the index and then summarize contract performance across the measures into one single HEI score for each contract. Then the index score ranges from -1 to 1, where -1 indicates contract performance is in the bottom third for each included measure, which looks at enrollees with social risk factors, and +1 indicates contract performance is in the top third for each included measure for those enrollees with social risk factors. So I wanted to walk through an example to make this a little more concrete. For measure A on this slide, which represents one of the measures in the index, one of the star ratings measures, we look at performance for those with social risk factors, and this contract score in this hypothetical example was in the top third of performance for the measure, and it receives a score of 1 in that first row. Measures in the Part C and D star ratings are weighted. For example, process measures receive a weight of 1, outcome measures a weight of 3. So in this example, a measure weight of 3 for measure A is multiplied by the score of 1 that the contract received for a weighted performance score of 3 in that last column. For measure B in this example, the contract received a performance score of 0, which means that the weighted performance for that measure is 0 in the last column. So on and so forth. We do this for each star ratings measure included in the index, and total the weighted performance by social risk factors and divide it by the total measure weight. So in this example, it's that total column of 13 divided by the total column of 18 in this hypothetical example, and that gets you 0.722. The HEI reward then varies on a linear scale, and contracts are eligible for the highest reward if all measures are in the top third of performance. So contracts must meet a minimum performance threshold of more than 0, and one of those enrollment thresholds that I mentioned in order to qualify for a reward. If contracts meet the contract level median, LAS, DE, and enrollment threshold, the reward ranges from 0 to 0.4. And if contracts meet half of that contract level median up to the median enrollment threshold, they're eligible for a reward from 0 to 0.2. And that HEI reward is then added to the contract's overall or summary star rating. And just for background, the star ratings range from 1 to 5 stars, and they're rounded to the nearest half star when they're publicly reported. So this slide walks through an example of how to calculate the HEI reward. In the HEI index score example that I just walked through, the index score example was 0.722. So we then take a linear transformation to calculate the HEI reward. If for contracts meeting the contract level median threshold, they can qualify for a reward of 0.289 in the linear transformation. And this is because the maximum reward of 0.4 for these contracts is multiplied by the index score of 0.722 minus the performance threshold of 0 divided by the difference between the maximum HEI score and the threshold. If a contract is only meeting half of the contract level median, but not the contract level median threshold, and receives that same HEI score of 0.722, this would translate on a linear scale to a reward of 0.144. So that's because the HEI reward would equal 0.2 times the difference between the HEI score and the threshold, divided by the difference between the maximum HEI score and the threshold. So this slide shows some simulations that we did using the 2020 and 2021 star ratings. For MA contracts, we found that the median percentage of enrollees with low-income subsidy or dual eligibility and/or disabilities was 42%, and half that median was 21% for MA contracts. For PDPs, the median percentage of enrollees with LAS, DE, or disabilities was 14%, and half that median was 7%. So in the simulation, these would be the tiered enrollment thresholds. And the table below that shows the percent of contracts meeting those enrollment thresholds in the simulation. 33% of MA contracts in the simulation were at or above half the median, up to but not including the median, and 17% were below half the median. 39% of prescription drug plans were at or above half the median, up to but not including the median, and 11% were below half the median. This shows that most contracts were able to meet those enrollment thresholds. Further, in our simulations, 42% of MA contracts received an HEI score of greater than 0, which was the performance threshold, and 34% of them then received an HEI reward. Among PDPs, 47% received an HEI score greater than 0, and 40% of them received an HEI reward. In the simulation, the average reward for MA contracts with an HEI score greater than 0 was 0.109, and the average reward for PDP contracts with an HEI score greater than 0 was 0.16. And again, in the simulation, that would then be added to their summary and overall star rating. Okay, and I have the link here for the final rule, the 2024 rule, where we finalize this, and there's lots more details there on the methodology if you want to read more about it. And I've also listed the Part C and D star ratings mailbox if you have additional questions. Thank you. Any questions from folks in person?
Hi, Cameron Adams from Arizona Medicaid Access. For each of those, or for the ones that are applicable, were all social risk factors counted the same? All domains?
So I can start with HES, and the answer is yes. So again, for HES, since we've covered a lot since then, HES looks at race and ethnicity groups and those who are and are not duly eligible for Medicare and Medicaid or eligible for the low-income subsidy. Both grouping variables, stratifying variables were weighted the same or considered similarly for HES.
So I think the methodology for the HEI is a little different. So as I said, we use the single factor, which is the ADI and the dual eligibility. And so if and this rolls up from like, patient level. And then of course the ADI is more like the zip code. And so it's like, if you look at how the model works, right? So if we assigned a 1, if they had either one of those, and then it's a 0 if they don't have the socio-demographic factor. So that's how the model was created. Does that help?
Yeah.
Okay.
Okay, and for the Health Equity Index for Part C and D star ratings, we looked at low-income subsidy, dual eligibility, and disability, and those were all treated the same. So if a beneficiary had any of those, they would then qualify for the index.
So I guess just a follow-up question for all of those. Would it be at any point in time throughout the year, or is it at the time of service? Did they have to have one of those factors for the entire year? If somebody qualified for a low-income subsidy, for example, for 1 month of the year, or half of the year, did they, score a 1, for example?
So I think for HES, for dual eligibility or low-income subsidy, they would be in that group if they were considered DE or LAS for the entire year. So that's how we treated it for HES.
Yeah, so for the HEI, it's like, so for each of those measures, can you hear me? Does this work? Yeah. Okay, so it's like, so for the readmission measures, it's more like a 3-year performance period. And then so for the mortality measures, it was more like a 1 year. So in that particular performance period here, if that was a yes for the particular patient in question, then yes. So that's how it's considered, once per performance year.
So if
Right.
it was a 3-year period and they only had it for 6 months of that 3 year, then you would count them.
So we didn't have the low-income subsidy on that HEI one, right?
Okay.
Yeah, so it's just the dual eligibility.
Trying to keep track of all.
Yeah, no, it's very different, and I think the reason why it's done that way and could be a little confusing is because every program has different availability of variables and access to, right? So pretty much on the HEI, we use the claims data and the dual eligibility and the ADI. So we don't have access to a lot of the variables that we want to use for the SDF calculations through the claims. And so we are kind of exploring next steps in terms of what other measures could be included and if we were to include those, and then what other socio-demographic variables we would have access to. So it kind of limits what can be done with each of those, the scoring, depending on the data source and the programs as well. And the measures, because measures are different, like HEDIS measures, quite different from the claims-based measures that we collect for the hospital programs.
Does this work? Okay, great. So for the Part C and D star ratings, the Health Equity Index. It covers 2 years of data, and if a person only qualifies for social risk factor for one of those years, we would include them for having a social risk factor for that year.
Hi, you mentioned claims data and social economic factors like HEDIS. Are you looking to merge the two down the road so that you get more? Okay.
Oh, no, please finish your question. Did I?
Because
interrupt?
it
So-
seems like it's sort of siloed because the HES is more or less purely HCAHPS and HEDIS, while there's all this other claims information that you can use as predictors when you run the analysis so that you can get more accurate and less biased information?
Yeah, I appreciate that question. It's actually one that we've thought about, not specifically for MAHES, but for applying that methodology to other settings. So Sarah alluded to this in her presentation, but like the HEI in the MA setting, HES was designed to be flexible as well. So if, for example, in the future, we wanted to incorporate claims-based measures and not just HEDIS and CAPS, we absolutely can do that. Also, what I think you're getting to at the beginning of your question is thinking about some of these broader like SDOH measures, which currently we don't have in HES. We were sort of beginning to explore ADI like very, very recently. And then a paper like just came out about how ADI, they're doing some updates to the ADI methodology. So we're kind of like waiting to see when that comes out because we're very interested to see if ADI could be incorporated into HES in the future.
For the Medicare star rating, I'm curious about the weighting. So when you weight where does that weight come from?
So the weight comes from the weights that we already use for the Part C and D star ratings. So in general, like process measures receive a weight of 1 in the Part C and D star ratings, and they're rolled up into the overall star rating using those weights.
Thank you. I really appreciate your all's presentations today. So I think this is less for the MA at the STARS Health Equity Index because there's payment attached to it. But for the other two, how are you going to monitor change over time if you're actually, by putting in all this work, you're making an impact? And yeah, just what's your kind of process for your plan for dissemination and seeing if you're actually moving the needle by building it?
Want me to go first? As I said earlier, we are like in the very early stages of developing this HEI for the hospital program. And right now we have no plans of immediately implementing the HEI in any program. So this is just a first step to trying to explore the concept. And there's a lot more measures that hospitals report on, but those are not claims, and there's other measures. But I think the challenge is if we use the claims, then we have access more to patient level data. And then if you, some of the other measures, which are the processy types, some of those are like aggregate data. And so aggregate data does not really allow you to then link to the socio-demographic variable, and so then you have to take a different route. And so I think it's like still trying to figure out how we could use all of those variables. So currently no plans to implement in the program.
And so for HES, there are a couple of things that we're planning, hoping to do in the short-ish term. So I shared a bit about the dashboard. Our hope and our plan is to continue to update HES with most recent data that become available every year. And so that we hope we can start seeing trends, right? Although we can't attribute it to them, right, having received their HES, we don't know to what extent plans are using it simply through that mechanism, but we're interested to see over time how plans' HES performance looks as we calculate it every year. Another thing that we're doing, sort of one of those blocks that I showed on the last slide, was some of the efforts that we're doing right now around plans for training and how we're going to engage with plans beyond just sort of passively, right, sharing their dashboard with them. We want to find ways that are meaningful and helpful to plans to engage with them, to make sure that they're understanding what they're looking at, that they know what resources, what to do with the resources we've provided, to get feedback from them on other resources we can provide. So we're hoping to, in conjunction with doing all of this like math, right, around calculating HES and continuing to do so over time, what can we do and what are the best avenues for us to engage with plans on the training piece and help them do the various health equity activities that they'd like to do.
And then I'll just take a moment for an online question. This is from a participant. How does HES align with the Health Equity Index from the recent CMS rule?
That's a really good question. Can I bring up a slide? Yeah, okay. So we had an appendix slide thinking this question would happen. We have actually two slides here. So the first one is the sort of key components of each of these measures, and the next one is about the methods. I think the most important thing to know, and like the biggest thing on everyone's mind, is sort of there are these two indices or methodologies in the MA space. How are these similar? How are these different? The important thing to know is that HES is not tied to payment, right? That's the biggest question we get. Will HES be tied to payment? Is HES the same thing as HEI? And the answer is no. HES is meant to be a equity-focused quality improvement tool. It has a number of different sort of methodological choices that were made because it's meant to be a quality improvement tool. Similar to HEI, probably important decisions were made because it's meant to be used differently. And so there, although data sources broadly might be similar, there are differences with regard to the stratification variables that we use. And again, importantly, ours is not and is never going to be intended to be tied to payment, whereas the MA HEI is. And then on the second slide, again, there are some important different methodological considerations as well about HEI and HES. So appreciate that question. It gave us a chance to show this table that we put together. So thanks.
I can add to that a little bit for the Medicare Advantage and Part D star ratings. The HEI also is reported for prescription drug plans, even though they don't receive quality bonus payments. So there is no payment implication for them, but we still think it's really important to publicly report that. And the index includes a broader range of measures than the HES. It looks at a wide range of the star ratings measures, so process measures, intermediate outcomes measures, and the patient experience measures. It also looks at adherence measures for the MA plans with the prescription drug plan component. It looks at HOS, Health Outcomes Survey also, as well as the medication therapy management measure that we have in the star ratings. And also, it is on the slide, the individual level stratification variables are slightly different for the Part C and D star rating HEI. We just look at dual eligibility, low income subsidy, and disability. I think those are the big differences to highlight.
There are no other in-person questions. I'll ask another from an online attendee, which is if star ratings are already high, where most plans get a similar high rating, will the HEI help offset these high scores?
The HEI doesn't offset the scores because it's an upside only reward. But we do, when we finalize this, we also removed the reward factor. So it sort of is balanced out. So it won't lower people's scores, the HEI by itself.
Any other online questions? No?
This is more of a clarification question, but how is disability defined for the star rating DEI? Was it based on diagnosis, functional impairment, or something else?
It's based on the original reason for Medicare entitlement.
Thanks. I guess just building off of that, has there been any discussion about looking at disability as a separate construct from the dual eligibility low-income subsidy? Because I know the entitlement, it links it to socioeconomics in that sense, but just looking at the differences in constructs and different populations that might be affected.
Yeah, we do discuss that a little bit in the final rule. I mean, we're definitely open to considering other social risk factors or different definitions of social risk factors, but we need the data at the beneficiary level. So it's something we're continuing to evaluate.
Yeah, but even using disability as defined through eligibility, it might just be a sample size issue, but any sort of evaluation of looking at them as two separate variables. So DE, low income subsidy, and then disability as a separate.
Yeah, I think we would run into reliability issues if we would only look at disability and then only look at LAS-DE. And just to note that we use the same definitions of LAS-DE and disability that we use currently for the Part C and D star ratings for the categorical adjustment index, so we wanted it to align.
There's one more question, a
Okay.
clarification question. MA plans are provided a HES for informational purposes and scored by a different index, HEI for scoring purposes.
Can you repeat the question?
It says, to confirm, MA plans are provided a HES for informational purposes and scored by a different index, HEI for scoring purposes.
So the first part of that, yes. They're given a HES for informational purposes only. But
Yeah.
they could also be given an HEI.
Right, which would be a methodological addition to the Part C and D star ratings methodology.
All right. Thank you so much for attending. We really appreciate it. Hope you have a great rest of the conference.